So I go over the indications for a central line, one of them being volume resuscitation, the anticipated need for vasoactive infusions, and if we think we're going to need to transduce for CVP monitoring. So I'll use those to make my clinical decision to put in a central line, go out and see my patient, explain the risks and benefits in pre-op, and obtain informed consent. And while I'm out there, I'm also going to go ahead and assess which site I'm going to use. The right side is preferable, has more direct access to the atrium. The left side is less direct, and there's some anatomical structures on this side, such as the thoracic duct, which could be cause for complications if we use the left side. So I'm gonna go with the right side. I'm gonna assess for any sign of infection, any warmth, redness, drainage, or anything. But the right side looks okay on this patient, so we're gonna do that. So I'm gonna bring the patient back, hook them up to our monitors, make sure we have the proper resuscitation equipment available. I will make sure my ultrasound's in the room. It's hooked up, ready to go. I've got my probe cover, and I'm gonna obtain any necessary supplies that I need that are not in my kit. So after reviewing what's in my kit, I see that I need a tegaderm as well as a biopatch for when I dress the site. So I'm gonna go ahead and induce the patient. I'm gonna place a central line after induction. I would position the patient optimally, slight Trendelenburg to cause some venous engorgement to ease my access to the IJ. Have the patient turn their head away from the access site and maybe remove their pillow too to make it easier for me. Next, I would identify my external landmarks. So I have my sternal head of my sternocleidomastoid muscle, my clavicular head, my clavicle, cricoid cartilage, and I'm gonna feel for my carotid pulse. I know my IJ is gonna be just lateral to that. Now we're going to open our kit. I've got my ChloraPrep here. I'm gonna clean the site. I'm gonna go down in a triangle from the sternocleidomastoid down to the sternum, across the ipsilateral nipple and back up. Give that a good scrub. Let that air dry. I'm gonna finish opening my kit. Have that ready. Now I'm going to don my sterile gloves and my sterile gown. Go ahead and open up my gloves. I'm gonna have coworker help me with my gown. Go ahead and drape the patient. I'm going to re-identify my landmarks. So got the sternal head of my sternocleidomastoid, my clavicular head, feel my clavicle down here. So I should be good. Now I'm going to go ahead and kind of get my kit together. Got my guide wire ready to go. My catheter, make sure my tip is intact. Make sure my distal port is open. The other two are clamped. Got my dilator. my scalpel with the cap off, ready to go. Got my needle. That's ready for use. All right, I'm gonna have a coworker drop my probe cover onto my sterile field. Thank you. All right, she will hand me the probe, maintaining sterility. Thank you. I'm going to apply the rubber bands, one right here, one right here. I'm going to apply the sterile gel to the patient. Go ahead and take a look, identify my internal lane marks. Gonna orient my probe. Okay. So I can see the carotid pulsating. Just lateral to that should be the IJ, and it is compressible. I'm gonna get my IJ into the middle of my screen. There we go. All right, so bevel up. I'm gonna go at a 45-degree angle, aiming for the ipsilateral nipple, aspirating as I insert, watching for the catheter on the screen. Okay, gonna have blood return. See it go through the vein on the screen. Blood is dark brown, so it's not arterial, or dark red, I guess. So I'm going to drop my angle, check, aspirate again. I do still have blood return. Advance my catheter without advancing my needle. Remove my needle. All right, I still have dark red blood. It's not pulsating, so I feel confident I'm still venous. As one method of confirmation, I'm gonna go ahead and insert my guide wire. To a depth of 12 to 15 centimeters. I'm going to go ahead and remove my catheter over my guide wire. And I'm going to see if I can visualize the guide wire with ultrasound. And go in an in-plane view. And I see it right there, so I know I'm still venous. My coworker turned my, okay, there we go. I can visualize it there. Okay. Now I'm going to utilize my scalpel to perform a skin nick away from the guide wire. Use my dilator. To ease access to the catheter. I'm gonna feel for the popliteal. And thread my catheter. Be looking for it exiting the distal port. I see it there. I'm gonna grab a hold of this, holding that stable, and almost do a push-pull with the catheter and the guide wire. Okay, go ahead and withdraw the guide wire all the way out. I'm going to aspirate and flush all of my ports. And clamp this. Okay, got return in that one. Okay. I'd flush all these back through. Go ahead and suture. Place my biopatch, place my tegaderm, go ahead and hook my distal port up to a transducer system, analyze the waveform, make sure it looks accurate for a CVP waveform, make sure it's secure, and proceed with the procedure.